for being with us again. And thanks for all attendees. They are and participants. They are with us today. And I hope today the connection, it will be more easier so they can connect easily, not like what happened yesterday, even though yesterday there were a lot of participants they share with us, and that's why there is a rush on the link. That's why it happened. There is a lot of people over the expected. Anyway, the first speaker for our session today, the cataract session, it will be about cataract in ocular comorbidity. First talk, it will be by Dr. Muhammad Ali Hisham, is a cataract and a surgeon in Maghrabi Hospital and medical director also of Maghrabi Hospital in Dubai. Also, he is a glaucoma specialist. Dr. Muhammad Ali, the mic with you, please.
Hi. I have no financial interest except, of course, my salary comes from the cataract and glaucoma. These are my references. The objective of this talk is to discuss the effect of the cataract surgery in glaucomatous patient, its effect of the cataract on the IOP control, and effect of the cataract on our investigations, how to interpret and how to just see the details of the visual field and OCT. The introduction is that the studies have suggested that the cataract surgery can reduce IOP in different types of glaucoma patients. Cataract surgery can improve the perimetric interpretation and optic nerve OCT interpretation. Cataract surgery can lead to filtering surgery failure, and this is one of the drawbacks of the cataract after trabeculectomy. Cataract and glaucoma surgery sequence determines the success of the rate of the complications. So which one is first, and this is what we're going to discuss: cataract first or glaucoma first or combined. Microincision glaucoma surgery has improved the outcome of the combined surgery. So the effect of the cataract surgery in IOP in open-angle glaucoma, several studies have shown that even in early 70s that during the intracapsular cataract extraction, ECC wasn't that much familiar to all the surgeons, have decreased the intraocular pressure. In mid-90s, there was a study by Matsumara showed that the average IOP after 3 years was 1.5 millimeter mercury of primary open-angle glaucoma after cataract surgery. Another study showed that after 5 years, that the cataract surgery in primary open-angle glaucoma and glaucoma suspect and normal subject had reduced the IOP. The average was 1.5 millimeter mercury. Friedman et al. Showed that there is 2 to 4 millimeter mercury reduction post-phaco and post-ECC. So this study showed the cataract surgery in open-angle glaucoma patients showed that the reduction of the IOP was about 2.5 millimeter mercury in the glaucomatous patient, and the higher the IOP, like if it's more than 21 millimeter mercury, the reduction would be 5.5, and if the IOP was within normal, the reduction was less. The study by Poli et al. Showed that 6.5 millimeter mercury in patients with preoperative IOP 23 to 31 millimeter mercury had a reduction of 6.5 millimeter mercury. If the IOP was between 20 and 22, the reduction was less, 4.5. And if the IOP was less, 18 to 19, the IOP was 2.5. And if the IOP was less, the IOP reduction will be less. Another study by Musburger, 3 years, the mean IOP reduction was after in ocular hypertension was 16.5%, and 40% maintained IOP reduction, and 20% had less than the 20% less than preoperative baseline. The pseudoexfoliation, of course, is very common that we see pseudoexfoliation, and pseudoexfoliation is the second leading cause of open-angle glaucoma. It deposits some fibrillar material on all the structures of the anterior segment, and during the pseudoexfoliation with the cataract, we have some complications. The zone units are weak. The dilatation of the pupil is very hard. So that's why we suffer with the patient with pseudoexfoliation. But the effect of the cataract in pseudoexfoliation by this study, which with more than 1,100 patients, followed up over 6 years, showed that there is reduction in the intraocular pressure. In another study by Estorm, found that the IOP reduction, that if the patient is done cataract surgery, the IOP will be stable. But if we don't do the cataract surgery, the IOP will come up 0.5 millimeter mercury every year. So cataract surgery can stabilize the intraocular pressure in pseudoexfoliative glaucoma. In narrow angle glaucoma, of course, we all know that in narrow angle glaucoma, cataract surgery is a glaucoma surgery. We know that 15 million persons had primary angle closure glaucoma in 2010. Most probably is much more now, and 50% of the blindness comes from the angle closure glaucoma. So effect of the cataract surgery in glaucoma, in control of the angle closure glaucoma, this is a study shows that the cataract surgery had 6.9 millimeter mercury reduction compared to 5.5 millimeter reduction in primary open glaucoma after the cataract surgery. In angle closure glaucoma requires less post-operative medication if we do cataract surgery. The outcome of the lens extraction for visual improvement in primary angle closure glaucoma, this study showed that the more the peripheral anterior synechiae there is, the more IOP reduction will happen. So if the PIS is more than 180 degree, the reduction will be more 7.5 versus if the PIS was less than 180 degree. The initial management of the acute angle glaucoma was discussed in a study by Hussein et al. And they found out that only 61% versus 89% with phaco IOL had IOP between 22 and 24 millimeter mercury. So the cataract surgery in angle closure glaucoma is very effective, but we have to notice here that it will not reduce. Like if a patient comes with a 30 millimeter mercury with all medication plus Diamox, we cannot expect that cataract surgery by itself will just solve the problem. Of course, we have to have either combined surgery or filtering surgery before or after. So the effect of the cataract surgery in narrow angle glaucoma was discussed again by Tam et al. To show the control of the glaucoma, and they found out that the IOP reduction was 8.4 millimeter mercury in phaco versus 8.9 millimeter mercury in phaco trap. So it's about the same. So doing phaco alone and phaco trap will give us the same result. And but the trap group required less glaucoma medication than the phaco group, and the phaco group had less complication than the trap group. How does it work? Of course, in angle closure glaucoma, you know that by doing cataract, the anterior chamber will be deepened and the angle will open and everything will just, and the trabecular meshwork will facilitate the aqueous outflow. It's different in the open angle glaucoma. We don't know what's happening in open angle glaucoma, but there are theories, just like remodeling of the trabecular endothelium with the ultrasound power vibration that we're using. The blockage of the microscopical in the juxtacanalicular trabecular meshwork can be removed by the ultrasound. Reduction of the deposition of glycosaminoglycan in trabecular meshwork due to the higher fluid flow rates, the irrigation aspiration that we're using. The inflammation that happens by itself induce some opening of the trabecular meshwork, juxtacanalicular trabecular meshwork, like we're doing in SLT and trabeculoplasty. The alteration of the blood aqueous barrier can reduce the IOP as well. And the traction during the cataract surgery, traction on the zonules can open the trabecular meshwork. So there are theories, but actually we don't know what's happening. As we said, the cataract surgery can improve our interpretation of the OCT and the visual field. And this study showed the effect of the cataract surgery on OCT and visual field, and showed that the OCT, either the time domain or spectral domain, and the perimetry, showed that we can improve actually our interpretation. It's much easier to interpret and more predictable and more persistent. This study by Rao et al. On the visual field, of the cataract extraction on the visual field, and showed that the mean deviation improved from 11.74 to 10.52 post cataract surgery. The same study by Siddiqui et al. On the CETA on glaucoma, they showed that the mean deviation improved from 12.3 to 11.1 after doing the cataract surgery. This doesn't mean that the visual field improved. It's only the patient can see better, so he can make the right decision to push the button. However, the PSD,
we are already
didn't have any significant. Okay, it's a few minutes. So what to do first, cataract surgery or the glaucoma surgery? It's a dilemma. Everybody has his own opinion. Cataract surgery cataract surgery can make the trabeculectomy fail, and if you do trabeculectomy first, it might not be controlling the IOP fully. The risk of cut of the endothelia and endophthalmitis on the long term of trabeculectomy has been discussed, and show that another study showed that 20% eventually will need cataract surgery post trabeculectomy. So why not doing the cataract first? So cataract surgery, if we are doing the temporal tricornea incision, so doing the cataract surgery first it will not harm the filtering surgery later on, because we are not touching the conjunctiva actually. So doing the cataract surgery and expect some of the reduction of the IOP, and later on we can do the trabeculectomy is a good idea actually. And as I told you, it can improve the IOP.
Dr. Mohammed, we are already finished. Can you conclude?
Yeah, it's only I just want to see that the only exception is with the angle closure glaucoma. So I will just go to the conclusion. I just wanted to examine some of the MIGs, but you don't have the time.
Yeah, but okay.
Cataract surgery has been shown to decrease the postoperative dependence of the glaucoma medication, and cataract surgery can buy some time before doing the filtering surgery. Thank you, guys.
Thank you, Dr. Mohammed, for your excellent and comprehensive talk. We hope that we have time to discuss, but unfortunately you take all. It was 10-minute talk and 5-minute discussion, but it exclude all in the talk. So we'll go to the second presentation. If we have time at the end, we can do discussion. The second talk, it will be by dear friend, Dr. Hamdi Abdelhadi Abdelmajid. He's going to talk about cataract and corneal opacity. He's a cataract and refractive surgeon in Libya, Tripoli. Dr. Hamdi, you can start share your screen, please.
Thank you, Dr. Mohammed. I don't know where is my screen. Is this one? Or?
I need everyone to open his presentation. Whenever he will shift to him, immediately he just share the screen. Okay. So we'll not lose the time.
Okay. Can you see my screen, Dr. Mohammed?
Yes. Okay.
Okay. And my talk today will be about corneal opacity. And as we traditionally learned previously, that whenever we are talking about corneal opacity, even during our undergraduate teaching or in the postgraduate teaching that the only solution for the corneal opacity is doing corneal surgery, replacing that opacity with a nuclear cornea. And that is a real problem that I started facing later on in my life, because a lot of my colleagues, they convince the patient that they will not do good if they remove the cataract only, and they have to do it as a combined procedure, removing the opacity, implanting a corneal graft, and then doing the cataract surgery to get all together in one session. Now, I started a few years ago for this, for example, this first patient that I'm going to show a clip of video for him. He's a patient that I have that over 10 years ago, and he have a posterior subcapsular cataract. He presented to me with a counting finger 3 meter. He's one-eyed, and that corneal opacity, a lot of people advised him of doing a combined procedure, doing penetrating keratoplasty with cataract surgery. As you can see here, there is a good red reflex coming from the back of the fundus. So I could manage doing the capsulorhexis carefully. And you can see that the corneal opacity is in an area. I avoid that area.
Video is not working, Hamdi. Are you playing a video? No.
Yes, I'm playing the video. You are not seeing the video?
No, video is not moving.
How can I share it?
Okay, just click on the video itself.
This is the video.
Okay, make it work here.
Now you can see it?
No, I thought you are.
Can you click play?
No. Replay? Here, it's playing now. Is it okay? You can see it?
No, it's not playing with us.
I will do a new share, maybe.
Okay. Okay, now it's working.
Okay,
good.
Now?
Yes. Before you are only not showing a full.
So
okay.
It needed only a new share. Now we'll start the video from the beginning. This patient, as I told, he was counting finger 3 meter due to a posterior subcapsular opacity with this corneal opacity, posterior subcapsular cataract. So what I did is that you try to avoid the area with the dense opacity, and you start your capsulorhexis, and you try to do it slowly and carefully in order to be able to see. And at the time of while doing the surgery, you try your best to move the eye to the right a little bit, to the left a little bit, in order to avoid and to have a better view while you are working, either while doing the capsulorhexis or while doing the phaco surgery later on. And even when you put the IOL inside, you have to check that all of the optic and the haptics are inside the bag. Can you see me? Can you see the video?
Yes, we are working. Yeah, continue.
Yeah.
Now it's okay. Can you move it because it's stop?
Yeah. So, Dr. Muhammad,
I think it's not moving.
To somebody else until I try to
No, it's taking your time from your time, so you cannot shift now, Hamdi. Already 5 minutes is work, so you can go to another one.
Yeah.
Can you share the screen again, Hamdi, please?
Share the screen again. Okay.
Okay, but it's not okay. Play.
It's not playing there.
Okay, there is any other video? Only one video.
Well, sorry to say that I did all of my surgeries in a single video, and they are here.
Okay, if you want, we can jump. We can take the second speakers, but if we will go back to you later. Okay.
Yeah.
You can try another one, or you want us to move?
I will try to do that. Okay, thank you.
You will try or later?
No, I will try later.
Okay. Sorry, Hamdi, for that. Can I have now Dr. Rajesh Fogla is here? Yeah. Hi, Dr. Rajesh. You are mute.
Hi.
How are you? Nice to see you again.
Fine.
Dr. Rajesh, he will give a talk about cataract and corneal endothelial pathology, DMAC versus DSAC.
Okay, let me share my screen.
Yes.
So can you see my screen?
Yes.
Okay. At the outset, I would like to thank this opportunity for involving me in this meeting. The
Our
topic
pleasure.
that I'm going to talk about is cataract surgery when you have endothelial changes, notably the Fuchs dystrophy. Fuchs dystrophy, described in 1910, it's a bilateral corneal dystrophy affecting the endothelium. The signs often precede the symptoms. You typically get the guttate changes, which is thickening of the descemet membrane with loss of endothelial cells. It has autosomal dominant inheritance, predominantly seen in females. Clinically, you will see this situation where you can see a beaten metal appearance of the descemet membrane and the endothelium. And if the patient has a coexisting cataract, this can be a tricky situation, especially in terms of decision making. So the changes can be observed either on slit lamp. You look at the orange peel appearance. You can see that on retroillumination as well, or you can do a specular microscopy where you see the dark spots where the loss of endothelial cells. You can do an anterior segment OCT, which will give you an idea about the corneal pachymetry across the cornea. And if you look at the cross section, you will see the thickened descemet membrane and the hyperreflectivity from the guttate changes on the endothelium. Now, in terms of, you get the development of guttate, loss of endothelial cells with pleomorphism, polymegatism, you get increased corneal thickness, posterior stromal folds, leading to epithelial edema and bullae, subepithelial fibrosis if the edema persists for a longer time with scarring and peripheral vascularization. Symptoms of glare, decreased contrast, blurred vision, especially early morning blurring of vision is very typical of decompensating endothelium. And if there is associated lenticular changes, the patients can present earlier. And the decision at that point of time is whether to operate the cataract or think about doing a combined surgery. The decision also depends on the patient's expectation and the clinical findings, and we have to use a tailor-made approach depending on what we see clinically. It's important to understand the normal pachymetry distribution in a population, which can range anywhere between somewhere between 450 microns going all the way up to 620, 630 microns. So there is no typical cutoff value which you can say that beyond this, you cannot do a cataract surgery alone. And in cataract surgery, there is an attrition rate of about 8 to 10% of endothelial cells, and which is also dependent on the density of the cataract, the anterior chamber depth, the dilatation of the pupil. And normally when you have a compromised endothelium, you try to use the soft shell technique, using a dispersive and cohesive viscoelastic to protect the endothelium. And in this paper by Seetzman, where they analyzed eyes which had pachymetry values of more than 640 microns, and when cataract surgery was done, out of that, 22.2% of the patients required to have keratoplasty, whereas those with corneal thickness less than 640 microns, only 2.4% required a subsequent cataract surgery. So that gives you the idea where people have been using 650 microns as a cutoff. But remember that in the normal population, even the normal pachymetry can reach up to that level. There can be outliers, which is pachymetry in the range of about 620, 640 microns. The advantage of doing the cataract surgery alone is that you get better refractive outcomes. You can avoid the potential complications of donor dislocation, graft failure, secondary glaucoma, risk of rejection. Patients don't need to use medications for a longer period of time, and you don't need frequent follow-up. What type of cataract surgery you do? Usually you do phacoemulsification, but if you have a very dense cataract, you can think about doing a manual small incision cataract surgery or an extracapsular cataract surgery when you have a compromised endothelium as well. In choice of IOL, use a hydrophobic IOL, thinking in mind that the patient may require a subsequent endothelial keratoplasty. Aim for a IOL power selection of about -1, -1.5, because endothelial keratoplasty gives rise to a hyperopic shift. Use sharp knives because you don't want to create focal decimus detachment at the site of your site ports or the main entry. I already mentioned, use the soft shell technique, use BSS or BSS plus, and avoid intracameral medications which can result in endothelial toxicity. End of surgery, suture your wounds with secure your wound with suture rather than stromal hydration, which can further worsen any DM detachment. And always leave a mid-size air bubble in the AC at the end of surgery, because this can, if there are any partial DM detachment close to your main entry or the site port, this can be addressed by the air bubble that you leave behind. Post-operatively, you may need to use steroids for a greater frequency initially to help the compromised endothelium recover faster. Topical 5% sodium chloride can also be used to manage epithelial edema if present. Monitor the IOP, always watch out for DM detachment. And if there is any corneal edema, it usually takes somewhere between 8 to 12 weeks to resolve. So don't be in a rush to refer the patient for a corneal surgery. There is increased risk of endothelial failure if there is already pre-existing epithelial edema or presence of folds in the posterior cornea, or if you see subepithelial fibrosis, or the guttate changes extend all the way to the periphery, and if you're not able to measure any endothelial cells on specular microscopy. Usually what we do in clinical practice is that if the pachymetry is less than 650 and your cell counts are more than 1000 microns, 1000 millimeter cells per millimeter square, you think about doing a cataract surgery alone. If it is more than 650, but the cell counts are between 800 to 1000, you can think about doing a cataract surgery alone, but there is a greater risk of postoperative edema. And if the pachymetry is more than 650 and the cell counts are less than 800, then maybe better to plan for a combined surgery. But we have been traditionally using grading Fuchs severity based on pachymetry and the presence of corneal edema, but there are certain new parameters that have been described. So this is a nice paper where they looked at the tomography, and here they also look at the regional pachymetry, and they find that the thinnest point is no longer at the center part, it's slightly displaced away. And if you look at the posterior elevation, you will find that there is a posterior depression. That means the posterior cornea actually, when you develop cornea, the posterior curvature, it kind of moves backward, and that results in this posterior depression. And if you see this, you know that there is this cornea is edematous, and it's going to progress further as the Fuchs dystrophy progresses. So sometimes before you see the changes on the anterior surface, you can see changes in the posterior surface. The other thing they have been also looking at is the ratio of corneal thickness between the center and periphery, because as you get increase in the thickness in the central cornea, the ratio between central and periphery, it reduces. And that can also give you an idea whether this cornea is going to fail subsequently. And newer three-dimensional anterior segment OCT can actually allow you to get some sort of measurement of the guttate changes, which can also, you can look at it in a physical way and see how worse the spread of guttate changes is in the posterior corneal surface. If the guttate changes are only located in the central part of the cornea within the central 4 to 5 millimeter, you can do a procedure that's been described as decimate stripping only. Unfortunately, in India, we don't see patients in this early stage.
Dr. Rajesh is mute now.
Dr. Rajesh, I think there is interruptions. Dr. Rajesh?
Connected, am I still?
You have been actually.
We
lost you for a second. We lost you for a few seconds. Okay, you can continue. No, if you can go back to okay. It's okay.
No, this is fine. I'll just show the procedure. So basically here, the central 4 to 5 millimeter is marked. You put cohesive viscoelastic into the anterior chamber, and then using a microforceps, just like you do a capsulorhexis, you do a decimetorhexis only in the central part, and you remove the central part of the decimus membrane that has the guttate changes, and then you wash out all the viscoelastic, and this allows the peripheral healthy endothelial cells to slide to the center, and over a period of 2 to 3 months, the central cornea becomes clear. And this can be further assisted with the use of topical Rho kinase inhibitors, which can assist the speed of recovery. So like ripasudil or netrasudil. And this uniform result.
Yeah, you're in.
Disconnect again.
Central guttate changes, and it's affecting the. Am I disconnected? But
yeah, you are. It's not interrupted. But go ahead. You are okay.
Okay, fine. But if you have advanced changes like this, then you have to think about doing endothelial keratoplasty, which can be either a ultra-thin DSEK or DMEK. It is definitely better than traditional penetrating keratoplasty because you get more predictable refractive outcomes, and the risk of rejection is much lower. And you can also combine it with cataract surgery. So when you combine it with cataract surgery, basically in the endothelial keratoplasty, you go ahead and do a Decimet stripping over a large 8 to 9 millimeter diameter, and you remove the unhealthy Decimet membrane. And this is the DSEC procedure where we are pulling in a healthy donor lenticule and into the anterior chamber using a microforceps, and then you can unfold it. There you can see the graft is unfolded. So that's DSEC. And in DMEC, you do an isolated transfer of the Decimet membrane alone, which is stained with trypan blue dye to enhance visualization. And once it is inside the anterior chamber, you unfold it. And you can see here, there is a F stamp, which is there, which helps us identify the correct orientation of the Decimet membrane. And once the Decimet membrane is in the desired position, you put a large air bubble to hold it in place. This is a DSEC procedure. This is a 11 years follow-up, and you can see that the cornea looks pretty clear. The advantage is there are no corneal incisions, so the topography is better maintained. You get faster visual rehabilitation. And this is, again, a DMEC procedure, a 3 years follow-up. You can see that the cornea looks pretty great with good cell counts. The recovery is very fast. Even within a week's time, your patient can achieve 6/12, 6/9 vision from an edematous cornea as well. And when you combine it with cataract surgery, the outcome of the triple surgery is quite good. And the combination of cataract surgery to DMEC does not affect its outcome. This is one of my patients who has had one eye surgery, and a week later, we operated the fellow eye, and the patient did very well. So you can do a sequential surgery also pretty quickly. This is a phakic eye with Fuchs dystrophy, where again, a DMEC was done. And you can see that this is again a scenario where you don't need to do cataract surgery. Even if there are minimal lenticular changes, you can do DMEC surgery first. And later on, you can plan your cataract surgery, and you can put in whatever premium IOL you want to put, whether it's a multifocal or a toric lens, because you don't have to worry about the corneal changes that take place. That's the OCT image. The refractive shift in DMEC is much lower because it doesn't induce any changes in the posterior corneal curvature. When you do get myopia, the posterior curvature shifts inward, and that creates a little bit of myopic shift. And when the resolution of edema happens, the central corneal edema resolves much faster, resulting in a steeper central curvature, giving a slight hyperopic shift, which settles over a period of 2 to 3 months. The outcomes of cataract surgery after doing a DMEC is, this is a paper published by the Melis group from Netherlands, and they found that the doing phacoemulsification after in eyes which have already had DMEC does not hamper the DMEC graft in any way, and the outcomes are pretty good. This is one such case where there is an anterior subcapsular cataract which was operated. So with lens changes, the option are you can do cataract surgery alone, explaining to the patient that if it fails, you may require endothelial keratoplasty. If the changes are limited to the central cornea, you can do only a Decimet stripping only, or Decimet stripping without endothelial keratoplasty followed by cataract surgery later. You can combine it, or you can do a DMEC first followed by cataract surgery later. So this is my last slide, which is a flowchart that I use for decision making. So if you have a patient with Fuchs dystrophy, if you have an asymptomatic patient, you just observe. If you have a symptomatic patient, and if the patient has a clear lens, then you don't need to do a cataract surgery. If the guttate changes are located in the center, do a Decimet stripping only. If the guttate changes are extending to the beyond the 5 millimeter, the anterior chamber depth is adequate, and the pachymetry is more than 650, you can consider doing a DMEC alone. But if the anterior chamber depth is shallower, you can think about doing a hard cataract, then you can think about doing a combined cataract and endothelial keratoplasty. So I think this sums up what I wanted to convey, and I think I hope you have found my talk useful, and it should allow you better decision making when you are faced with a patient with endothelial changes and a coexisting cataract. The newer diagnostic method can help quantify the corneal changes.
Yes, we are having 1 minute. Okay, please.
Sure. The choice of procedure depends on the patient's expectations. In future, the cell-based therapy may further change the management of these kind of cases. Thank you. Thank you for your patience.
Thank you very much, Dr. Fugla, for this very nice and excellent presentation comprehensive, and we need to share with us also your flowchart. That one we can share for everybody to get benefit from that. Thank you, but unfortunately also there is no time for discussion. Maybe later on in the end of the session we can go directly to Dr. Ahmed Akman. He will talk about cataract in ocular surface disease. Dr. Ahmed is a cataract and glaucoma, cornea and refractive surgeon in Ankara, and he is going to talk about cataract in ocular surface disease. Dr. Ahmed, mic with you. Yeah, we can't hear you, Dr. Ahmed. Are you on mute?
Okay, sorry.
Yeah.
Nice to be with you today again, and thanks, Mohammed, for this great meeting. I want to talk about cataract in ocular surface disease. Sorry, these are my financial disclosures, and these are my references. So, ocular surface disease is a part of daily life. We practice in an area of refractive cataract surgery. Femtosecond laser cataract surgery and premium IOLs resulted in very high patient expectations. However, we generally overlook the fact that these advantages can be lost with slightest disruption of the tear film. Ocular surface disease is exceedingly common in the cataract age population, and presence and exacerbation of OCT can negatively affect IOL calculations and postoperative visual acuity. So how we define the ocular surface disease? At first, we have to define the ocular surface, which is the cornea, conjunctiva, eyelids, and lacrimal glands. Any disorder in these structures can be classified as OSD. We have dry eye disease, blepharitis, meibomitis, meibomian gland dysfunction, allergic eye disease, and burns in this group. It's a very high incidence disease. It's around 60% of routine cataract patients were asymptomatic, but they had central corneal staining in one study. In another study, the incidence of OSD in patients presenting with cataract surgery was over 80%, and most of them were asymptomatic. The impact of dry eye disease and ocular surface disease on topography, biometry, keratometry, and high order aberrations is one of the major causes of the disappointing postoperative results. What are the subtypes? There are a lot of different classifications, but in the CEDARS 5 classification, we have this first subtype, which is the aqueous deficiency. The second subtype is blepharitis and meibomian gland dysfunction. It can be evaporative or non-evaporative. Third subtype could be goblet cell deficiency, mucin deficiency. Fourth is exposure, and fifth subtype is the dysfunctional tear syndrome and some co-constipators. What are the signs? We all know these signs quite well in our dry eye patients. We can have staining with different stains. We can have different kind of meibomian gland dysfunction or meibomian gland problems. With the OCD tests, we have a lot of tests practically we do in everyday life, like meibomiography, osmolarity testing, Schirmer testing, ocular surface staining, in vivo confocal microscopy, OCT, or tear film breakup time. What happens during the cataract surgery? Cataract surgery is a surface damaging event. It's important to nurture the ocular surface in patients in both pre and post-operative period. Ocular surface preparation can be beneficial not only in patients with established disease, but also in those with minimal signs or symptoms of OCD. Surgeons should identify patients who are at the risk of exacerbation of ocular surface disease. We have to check and optimize the tear film stability preoperatively, minimize intraoperative dry eye with an appropriate surgical plan, maximize outcomes with aggressive postoperative management to restore the surface integrity, try to ensure long-term maintenance of the ocular surface. We must have a systematic approach for ocular surface disease to identify the magnitude and impact of ocular surface on cataract surgery. We have to make a preoperative assessment and optimize the ocular surface in the preoperative period. This is the last algorithm from American Cataract Refractive Surgery Society, which looks quite useful, but the algorithm can be a little bit confusing. The aim of Ascaris was to tell people, although over the 90% of the respondents for the Ascaris surveys felt even mid to moderate dry eye affected patient satisfaction after cataract and refractive surgery, less than 10% were using currently available point-of-care diagnostics in the routine preoperative assessment. So American Society of Cataract and Refractive Surgery tried to find a diagnostic algorithm and treatment recommendations that can be tailored for preoperative patients. This is the algorithm. I want to show it in 3 parts. You can find it on the Society's website. It looks quite complicated, but actually not. I can tell that most important part is the clinical exam. You look, lift, pull, and push, look to the blinking and lashes, lift the upper lid and examine the superior surface, pull to assess the laxity of the eyelids, and push to see how the lacrimal glands working. In the second part, you can rule out ocular surface disease, or you can tell there is ocular surface disease. Then you go with the second part of the algorithm before proceeding to the surgery. And in the last part of the algorithm, you control your treatment plan and plan the surgery if all the problems are solved. Also, we have the speed to pre-op OCT questionnaire, which is quite helpful for everyday practice. And we have the DIVS treatment algorithms. Probably Dr. Osama Giledi will be talking about these, so I will passing them. So, in conclusion, ocular surface disease can be detrimental for cataract and refractive surgery. We must identify it correctly and treat it aggressively preoperatively. We have to monitor patients and continue treatment if necessary after the surgery. Thank you for your patience and hope to see you after this nightmare is over in my wonderful country. Dr. Mohammed, I think you are also, okay.
No, I am with you. Thank you very much. It's an excellent and on time. Maybe we can use, we can go to the next talks. Maybe I will keep I'm collecting all the questions, so to the end of the sessions.
Dr. Mohammed, unfortunately, I have to leave for a surgery now. So if you have questions, maybe it's better to finish them now.
So I will give you only, I have one question. If there is any question, Dr. Imad here, Dr. Imad William, we are with us.
Dr. Ahmed, can you stop sharing?
Stop sharing.
Sorry.
Yeah. Okay, Dr. Yahya, you can go share. Okay. Dr. Osama and Dr. Imad, are you there?
Yes, Dr. Muhammad, yeah. No, it was very wonderful.
Okay, you have any question, Dr. Imad?
No,
to
no,
Dr.
Thank
Ahmed?
you very much. Everything goes
Okay,
through.
Doctor, I have only one question. As you mentioned in the beginning, that 80% of our patient, and in some studies 60%, they are having ocular surface disease while we are doing a cataract surgery. But what is the most important thing that prevent us to go for ocular surface disease? I mean, to surgery from the ocular surface disease. What is the most important diseases or something that prevent us to go for cataract surgery? We have to treat before doing the cataract surgery.
The important thing is these. I think these percentages depend on the climate a lot. Ankara is a very dry part of the Turkey, and we have a lot of patients. But I think we have to take care of the meibomian gland dysfunction and dry eye at first. The other ones are not so common, but just a small show you how important it is. One of my patients who I put a panoptics lens for clear lens extraction, she was having 20/20 vision, and one day she came back, I'm blind, I can't see. Her vision was 0.3. And just putting one drop of artificial tears, she says, what are those drops? Only one drop make me see again. So dry eye is, I think, the biggest one. Evaporative, aqueous one, and I think the meibomian gland dysfunction.
Thank you very much, Dr. Ahmed, for your excellent presentation. On time, as usual. We'll see you also tomorrow. I know that you will be with us again. It's our pleasure.
Thank you very much for everything.
And good luck for your surgery, and we'll see you tomorrow. Thanks a lot. So we are now going to move to our dear friends, Dr. Yahya Salahuddin. He will give the first presentation about cataract in traumatic eye. Osama, you will be with Dr. Yahya. So you are the one who is going to manage Dr. Yahya, because I cannot, he is a big boss and he need one also big boss.
No, I think he managed very well his time, so it's fine.
No, he's not the time, discussion. I know, no, Dr. Yahya is in the time, is perfect. Okay, Dr. Yahya.
Thank you, Dr. Mohammed. I'm going to talk about an important subject, which is traumatic cataracts. And we want to have an overview of the ocular trauma classification as a start, and discuss the different scenarios, how to manage and when to operate in these patients. And these types of cases are usually seen in university hospital or tertiary care hospitals where these patients are referred. So it's a very important topic for all of us, and particularly also younger colleagues, to have the way to take a decision. And we should know that trauma is the leading cause of unilateral blindness in the world, and it's highest among individuals in their 20s, which is they have a long life expectancy. And we can have also open globe injury poses a lot of challenges in the therapy. So we have to have a systematic approach to diagnosis and the basic surgical principle. And we can see the causes as different from
Victoria, you are not sharing the screen, right?
No, I'm sharing the screen.
No, I thought that you are sharing, you are talking about not sharing.
Okay, so the causes can be from car accidents, work at home, glasses broken, so many different causes that we know. So I want you to have a look at the classification of eye injury, having closed globe injury or open globe injury, and in closed, both of types of injuries, we can have associated cataract formation. And in the closed trauma or closed globe injury, we have the coup and contra coup damage that can lead to subluxation of the lens in the topic we're talking about. And of course, the open globe injury, whether it's a rupture or it's a perforation or penetrating injury with or without intraocular foreign body, can have associated cataract formation. So let's go into more focus on the different presentations of the cataract surgery. You can see the patient presenting with you with the primary rupture or open globe injury, or you can see him after the repair of the rupture. You can see him in different situations, associations, different associations, like the examples I'm giving here. So we have to think when we see these patients of the comorbidity, like the glaucoma and angle recession glaucoma, the presence of vitreous hemorrhage, retinal detachment, the open globe injury, and how we are going to manage, and the presence, and we should always exclude intraocular foreign body in cases of trauma. Trauma of the lens, we can have closed globe injury, and the typical one is the sunflower cataract, and this usually we will treat it as a regular cataract. There's no specific things about it, except that we should exclude the occurrence of associated glaucoma or other comorbidity. We can have subluxation of the lens, and we'll make a tackle on this. Or we have open globe injuries. So we have questions in the open globe injuries. Should we operate simultaneously with repair of open globe injury? And this is a very frequent question and a dilemma that we have to think about. And what's the best scenario for managing these cases? We should ask ourselves, do we have a ruptured anterior capsule and probably posterior capsule or not? If you have an open anterior capsule with no lens matter in the anterior chamber, we can defer probably the surgery for later on, after a period after repairing the open globe injury and managing. If we open anterior capsule with a lot of lens matter in the anterior chamber, probably this is a challenge to do a primary surgery, and we should ask ourselves how extensive is the opening in the anterior capsule, and is there a possibility of posterior capsule rupture or not? And we should have this in mind, and we use different tools like the ultrasonography to help us, to guide us that probably posterior capsule rupture, because the management you should be more prepared, as well as the clinical sense from the history and the way of the trauma. So simultaneous cataract removal, it has some challenges. You have difficult biometry, bad visualization, anterior chamber stability issues, risk of increased postoperative inflammation because the eye is already insulted, and the definite risk of infection. So these are the reasons why we should think that we might not do primary cataract removal with trauma. So sequential cataract removal will allow us to do a proper biometry, so better visual rehabilitation, and we know that the cornea has settled and the topography is better, so we can have better judgment, better evaluation of the situation. If there is subluxation, if there is iris trauma, preparation for the surgery plan, including iridoplasty, decreased possibility of postoperative inflammatory response that we have controlled in the time between the trauma and the surgery. And there has been many researches and papers done. Some of them, like this one, will say that the traumatic cataract caused by corneal scleral perforation requires correct operative timing and proper management. The early operation of intraocular lens implantation within 3 to 10 days is safe and effective, and this will guide us that we can do simultaneous work. But there are others that they will say there is no significant difference regarding the post-surgical corrected visual acuity and prominent intraoperative and post-operative complications. So let's go into different scenarios. Some of them, this patient was referred, this patient was referred with this corneal laceration with iris prolapse, and actually was sent for me that the patient has traumatic cataract. So what we want to learn from this is that you have to go step by step, repair the rupture with the laceration, evaluate the anterior chamber, because sometimes you can be misled. What you think is a traumatic cataract is not really a traumatic cataract, particularly in younger patients. The inflammatory response, even immediately, is huge, creating an inflammatory membrane. So after repairing in the proper way by starting with the limbal suture, forming the anterior chamber and trying to reposit the iris backward, then you can evaluate if there is cataract or not. And in this case, as you will see, actually, I found out this was an inflammatory membrane that is embracing the whole anterior chamber from angle to angle and covering the pupil, giving the impression to the primary surgeon or ophthalmologist who have referred the patient that this is traumatic cataract. But as you can see, it's only an inflammatory membrane that you can carefully peel off the lens, and you find that the lens is clear, so you can save a clear lens and you can stop removing unduly a clear lens, which is very important in evaluation and going in such cases step by step and seeing what is the problem to tackle. Another example is this lady that presented with rupture and the almost intumescent cataract, and from the history we could anticipate that the anterior capsule was open and there might be an opening in the posterior capsule, so we had to be careful. We have to revisit a wound if we think it will leak to ensure stable anterior chamber during removal of the cataract. Capsular stain is used here, and even if the anterior capsule is opened in one point, you can try to do a continuous rhexis as much as possible. Here it was possible, and as you can see, it's a soft lens. So working with low parameters, low infusion, trying to do phacoaspiration, and always keeping in mind that there might be an associated capsule rupture. So you use viscoelastic, manipulate the cortical material and the nucleus, and always be prepared. Always be prepared. Have a standby, and you can see now there is an open posterior capsule. You can see now an open posterior capsule. You can see an open posterior capsule that you try to, with a low infusion, move the cortex before you have any vitreous prolapsing. This is a vitreous strand. Then you start doing anterior vitrectomy, first dry to avoid any prolapse of more vitreous. You can do this through the anterior segment or through the posterior segment. And the sweeping movement assures there is no vitreous in the anterior chamber, which will eventually prevent proper placement of the lens. Here, you can see the pupil is rounded and injecting viscoelastic in the sulcus. I'm planning to implant a 3-piece lens, which is the best lens in these situations, to implant the sulcus, or you can do an optic capture through the anterior capsule. And then you check again, there is no vitreous prolapse. Here, it's another example of traumatic cataract that we can see a traumatic cataract, a boy with repaired rupture, open anterior capsule, eye injury. Then you have to tackle step by step, making sure that the wound is properly closed, and then managing the opened anterior capsule to get as rounded as possible anterior opening, and then removing the cortex. There is no opening in the posterior capsule in such case, and being a young patient, you can see now this is the anterior capsule. After doing irrigation spray now, Vanessa, I'm rounding the end of the capsule just to have a secure rounded edge of the anterior capsule. And being a young patient, I decided to do a posterior capsular access so as to avoid the need of YAG capsulotomy later on, because sometimes the visualization is not good through this corneal scar. And then checking the integrity of the capsule, and again using a 3-beam lens that here I can implant safely in the sulcus. because I don't have a proper capsular access, anterior capsular access. And then this assures good visual rehabilitation post-operative. The last example is that you can be confronted with a patient with blunt trauma causing subluxation, and you can definitely see that there is the subluxation here from the beginning of the surgery by seeing this fold sign indicating that the lens is subluxated. So you have, in this point, you have to change your strategy, make sure that you are going to work in low infusion pressure, you lower the butter, everything goes slow motion, and making sure with this type of vertical chopping to avoid stress on the zonules so as not to induce more zonulisis. One of the good things of traumatic zonulisis compared to congenital subluxation is that traumatic zonules that are injured will not increase by time. So if you have the lens positioned properly, it will stay for the life of the patient. In contrast to congenital subluxation, where it's a progressive disease, so you have to make sure how you fix the lens in the eye to ensure it is stable over a long time. Here, with the subluxation, I put a capsule tension ring. This is Sayoni, but actually I did not need to use the fixation of the Sayoni ring to the sclera, and again, using a 3-piece lens helped me to center the lens properly and to assure this patient proper visual rehabilitation. So I will conclude here that all trauma cases are unique. Optimal management often requires creativity based on a solid understanding of the pathophysiology and surgical approaches available. And traumatic cataract is a challenging problem and needs customized approach for each patient. Thank you for your attention.
Thank you very much, Dr. Yahya. I think your next talk is also yours about posterior ball cataract.
Can I have a question to Dr. Yahya and Dr. Osama?
Okay. Yeah, go ahead.
Dr. Yahya, thank you. Very, very nice, informative presentation. But I have a question for you that everybody knows that, in cases of traumatic cataract, there's a lot of reaction post-operatively. Do you have any measures to avoid this post-operative reaction, like injecting steroid or systemic steroid for the patient, injecting intracameral or subconj or whatever?
This is an important point, and this is one of the points of the arguing why we should try as much as possible not to do the primary surgery. So to decrease the post-operative inflammation, try not to do primary cataract and intraocular lens implantation at the time of repair unless you have to. Second, yes, if I'm doing it within a week or two, I give, at the end of surgery, posterior subtenon Kinacort, for example. And we use usually the topical steroids for a longer period than usual. I usually use it for 3 weeks. Here, I would use it for 6 to 8 weeks. And the younger the patient, the longer the period you need to give him anti-inflammatory.
And also, some people believe that they can give also on the day of surgery 500 mg methylprednisolone systemically. Is this will help?
I never, usually, maybe some people will do this, but I usually don't resort to systemic steroids in such cases.
Like intravitreal.
Local.
Intravenous.
Yes, I understand. Intravenous, I don't give, usually I don't resort to systemic steroids. I prefer local, either topical.
Okay, thank you very much.
Now, my screen, the new presentation is shared?
Yes.
Yes, Dr. Yahya.
Okay, so now we will move on to another a little bit rare topic, but it's an important topic, that we should talk about, which is the posterior polar in general, posterior subcapsular cataracts, and we should show the types and classifications if there are any, and discuss the surgical approaches and how to avoid the problems of patients. One of the things we should know is the posterior subcapsular cataract or posterior polar cataracts. This is a rare condition, but we often see. In a way, it's an autosomal dominant condition, so it means that it started in the young age. This is the typical posterior polar cataract, and we have to know two things about these patients: that it's the opacity, this opacity is adherent to the lens capsule, and the second thing, that the posterior capsule is weakened, and that's why we always fear in such cases, and we should be prepared in such cases that we can have an open posterior capsule. So this is the two words that we should remember in such cases. Presentation can be different, and actually, although I will show you some classification, but there is no real dependable classification because there is not huge numbers of studies or huge number of patients. But at the end, the most important is your clinical exam. The slit lamp examination, like the photo in the center, this is a posterior subcapsular. One of the characteristics of the posterior polar cataract that you should be a little bit afraid of is having, like in this photo, if you see my pointer, you can see this thickened part as if it is calcified and well delineated but corrugated edge of the posterior capsular opacity. These cases you should be aware of. Some rare cases like this, you can see from the beginning that the posterior capsule there is dehiscence and opening in the posterior capsule. And this is an easier thing that you know from the beginning of the surgery. The more difficult thing that you should always recognize or anticipate a problem before it happens. And many of the cases we see the posterior subcapsular cataract, we see it in a lot of diabetic patients. So it is not that you can see the contrast. These patients you should suspect, but most of the time there is no problem in such patients. Classification, as I said, there is no real classification, but there is a same classification, and it divided into 4 types according to how the opacity looks like, is there is a thin capsule or not. And another classification that is similar, that is talking about eminent, there is in the posterior polar cataract with eminent posterior capsular, with eminent posterior capsule dehiscence, or with pre-existing posterior capsule dehiscence, or with the spontaneous dislocation, like the case we saw it already, the posterior capsule is open. A suggested concept would be to classify this opacity according to the size and density of the opacity. The size, some people will say it can range from 0.5 to 3 millimeters in increments. Density would be staged from 1+ to 4+. All this just to help you to say this is a high-risk patient or not. One of the interesting papers was talking about using the anterior segment OCT to predict the posterior capsule rupture during phacoemulsifications in these patients, and it showed sensitivity of 100% and specificity of 94%. So this is maybe a way that we should think how to evaluate such patients. So I'll guide you. This is in different scenarios, posterior subcapsular case. Going as usual, because clinically it didn't look dangerous. But if you think it's a posterior polar cataract, avoid hydrodissection or do hydrodissection to the edges of the opacity. Don't let the wave passes to the other side, as we usually do for hydrodissection, or do only hydrodelineation to leave the last difficult part to the end without risking the opening of the thin or weak posterior capsule in such cases. This is vertical chopping. And again, in these cases, just make sure you are confident. You see, this is called pseudo hole. In such case, you can see this. This is in the epinucleus. But if you use high magnification as I'm using, you can easily identify there's no opening in the posterior capsule. And in such cases of posterior subcapsular, there are opacities on the posterior capsule that you can do vacuum cleaning by holding the posterior capsule like this. You can wash these opacities or cells and then implant the lens, because this was not a true posterior polar cataract. In other cases, like this one, you can see this is a suspicious, clinically you suspect that this could be a posterior polar cataract. So you have to be careful, make sure always to make a proper anterior capsular access. Hydrosection is not, you should not insist on doing extensive hydrodissection. Again, doing the regular vertical chopping with the infusion not high, so to avoid any infusion pressure that can jeopardize the posterior capsule. And then you can see in such case, although it is not a typical posterior subcapsular, posterior polar cataract, but still there is an opacity, an opaque plaque on the posterior capsule. So you try, as we said previously, to do vacuum cleaning, washing, and then if this does not work because you want immediate visual rehabilitation, you try to peel the posterior capsule opacity. Sometimes the opacity is in the posterior capsule. It is not in front of the posterior capsule that you cannot peel it enough to give you a clear visual access. You can see I'm trying to peel, it's peeling. And you have to be prepared for this. In such cases, always you have to think preoperatively that you might need peeling, you might need to posterior capsular access, you might be anticipated with an opened anterior posterior capsule. So you should be mentally and surgically prepared for this. Still, after peeling, there is opacity in the posterior capsule. Then you can move to do a primary posterior capsular access, following the rules that will allow you to do a continuous posterior capsular access without injuring or insulting the anterior vitreous face, which is an extremely important step. Why not to use YAG laser? YAG laser is not without complications. And again, I would like to give the patient the best visual rehabilitation immediately, so long you are following the rules of posterior capsular access by injecting the viscoelastic through an opening in the posterior capsule to push away the anterior vitreous face. You will not rupture or interrupt the anterior vitreous face. And hence, you can have a clear posterior capsular access with implantation of a one-piece lens in the capsular bag in front of the posterior capsular access, behind the anterior capsular access, giving the patient immediate visual rehabilitation after treatment of this particular type of cataract. This is a typical case of posterior subcapsular. This is the last case, the typical case of posterior subcapsular posterior polar cataract. You can see the type, how it looks in the center, how it's thick. These cases, you can anticipate thin, weak posterior capsule, opacity adherent to the posterior capsule, avoid complete hydrosection. I did hydrosection here, one side to one side of the opacity and injecting the other side to the opacity. And then depending on doing hydrolination and very careful phacoaspiration, trying to avoid the area of suspected probable opening of the capsule or weakening of the capsule until the end. You can see the cataract is coming over, and I am looking at the area of the posterior capsule opacity.
Dr. Yahya, we are already over the time.
Yes, it's done. Okay, so, and here, because it's weak, there is weak, it's an open posterior capsule, but again, you can convert this into a regular posterior capsular axis and moving on to implant the lens as the previous case. So in conclusion, posterior polar cataract is a rare but important entry for cataract surgeons. We should be aware of the risks and how to prevent and manage such cases. Thank you for your attention.
Thank you very much, Dr. Osama. I think maybe Dr. Hamdi, he can present now. Hamdi, you are there?
Yes, dear Dr. Muhammad.
Okay, can you start share screen as soon as possible, please?
Yes. Now I will go quickly over my video. I will try to forward it faster. My talk is about the corneal opacity and the possibility of do cataract surgery in these patients and providing them with the proper visual acuity for as much as possible, returning them to their previous life. This patient is about 55 years old of age. He came to me with this corneal opacity. He's one-eyed patient, and he was planned for combined BKB and cataract surgery. So as you can see here, as long as I can see a red reflex, I could manage to do for him capsulorhexis. And after doing the capsulorhexis, always you try to move the eye up and down, right and left, in order to be able to see clearly and not to cause any problem, because the best thing is you always have to do proper visualization. If you cannot see due to one reason or the other, whether the corneal opacity is too much or the cataract is too mature, you have to stain in order to have a proper visualization. Then you start moving the eye. As you can see, I used my chopper to move the eye a little bit inferiorly in order to be able to see where I am. Am I getting proper depth to make the cracking of the nucleus or not? Then in difficult cases, usually I'm very happy with the Simcoe cannula. So I use the Simcoe cannula, and you notice that these patients, because the procedure was starting to be prolonging, most of them, they will have meiosis. And the other problem that all of my 3 videos for today are for an old gentleman. So most of them are having prostate hypertrophy and using anti-prostate treatment. As you can see here, after you put the lens, you have to make sure that the haptic and the optic all are in the bag. I'm starting to forward, but the video is not forwarding quickly. So I'm sorry for that, Mohammed.
Okay, go ahead, Hamdi, it's okay.
Okay, so this was the first patient. He came to me later on, I think 5 years later. I find some difficulty in doing the YAG capsulotomy for him, but with dilatation, I could, with the use of the contact lens, do proper capsulotomy for him. And his vision is 0.4 vision. He's driving his car, by the way. He's from a nearby city and one-eyed, and his vision is 0.4, and still he's driving his car. So we have different rules and regulation for driving here. Now you can see here that this patient is having corneal opacity and meiose pupil. And there is this problem of anticoagulant that he's using. So once they give for him the local anesthesia, he developed erythropulbar hemorrhage. So we kept him for 1 hour or so in order for the intraocular pressure to be reduced. And then we carried on with our surgery because his condition was proper and we could do that. And you can see I'm doing the capsulorhexis here. Once you feel that you need to refill your chamber, or in order to see properly, you add Helon and you finish your capsulorhexis, and later on you start doing your surgery. The idea here in these patients is that always you have an opaque media, and you have to move the eye up and down, and you have to take your time. As you can see, we are using the VISC on the cornea in order to help in magnifying the image and making it clear all the time during the surgery. And also according to the new precautions, we are using it at the tip of the phaco at the wound in order to reduce the aerosols in the theater, as you can see. So you can judge that this patient is a new surgery. It's about 3 months ago. So the pupil here, as you can see, it's meiosed. I'm trying my best in all of my patients also to avoid using the retractors if it's possible. But if the pupil gets more and more meiosed, I use usually the iris retractors, which is the preferred thing for me. I have tried the other things, but I found it better in my hand to use the iris retractors. And in here, as you can see, I'm using the third hand of the surgeon, which is the helon, in order to position the cortex in a proper way for my phaco tip to get it easily. And after finishing that, we put the IOL inside, and you have to check all the time with the retractors that the IOL, optic and haptic, are inside the bag. So now you can see we are introducing the IOL. So once the IOL unfold, it will dilate the pupil a little bit, and you will be able to see more clearly. But once you introduce the other haptic, sometimes it can slip from you and you don't know if it is inside the bag or not. So you have always to check about that. And here is the difficulty, because the cornea is opaque, and at the same time, you are not seeing. So what I usually do is either that I inflate the anterior chamber a little bit in order to be able to see the edges, or sometimes I use the hooks in order to move the pupil away in order to see the rhexis well. At the end of the surgery, always I use Vigamox, and I inject it in the bag as a prophylactic antibiotic. Now, this patient, I have done for him the right eye about 4 years ago, and he came for me 2 weeks ago. I did for him surgery. I used adrenaline in him because he is using tamsulosin. And of course, you will be afraid of IFAS syndrome in such patient. He have a corneal opacity. You can see when I sweep with the stain under the helon, as I have learned from my mentor, Dr. Yahya Salah, what I'm doing is that you can see that once the cannula moves under the opacity, part of it starts to be hazy. And you can see now I'm starting my wound with a cystotome in order to have a controlled area and to be able to see it later on when I start my capsulorhexis forceps. And I try my best to do the capsulorhexis away from this opacity in order to be clear and easy. And then you start moving the eye in order to get to the point that you need, which is as deep as possible in your trench, with seeing, not with the feeling, because you have to see that. So moving the eye up and down, right and left, this will help. The problem with this patient is that I offered him surgery 4 years ago, but he was happy with the other eye because his vision was 6/9 in it. So he delayed this eye till 2 weeks ago when he came to me. So when I did for him the surgery, it was difficult a little bit. And he said that this eye doesn't see well like the other eye. He's seeing with it in the first week post-operative visit 0.3. So 0.3 is better than hand movement. As you can see, IFAS started now here by iris prolapsing, pupil getting meiosed. So you start trying to keep the depth of anterior chamber all the time stable.
1 minute, Hamdi.
Yes, sir. I'm about to finish here. So the only thing that I want to emphasize in here is that once you complete your surgery, you have to be careful about putting the lens inside the bag. In this patient, what happened with me that the other haptic, which is a modified C haptic, have disappeared under the pupil. but because I was paying attention, I noticed that it was not in the bag. So what I did is that I collect the haptic and I put it back in the bag in order to ensure that the haptic is inside the bag in order not to have a future complication of UGH. You can see now what I'm doing. I'm pulling the haptic toward the edge of the capsule and introducing it in the bag in order, because it disappeared, and you will see a rounded pupil. So if you don't search for that, you will miss it very easily. Thank you. I'm grateful.
Thank you very much, Hamdi.
Thank you all.
Thanks a lot.
Patience with me. Thanks. Bye-bye.
Thanks a lot, Hamdi. Thank you. There is some interruptions in the voice, but it was good. Great. At the end, we can see your video, Hamdi. Thank you. We are having 4 minutes for discussions. I will start with first question to Dr. Muhammad Ali. Is Dr. Muhammad Ali here? Dr. Muhammad?
Yes, I'm here.
Okay, Dr.
Yes,
Muhammad, is the reduction in IOP is long-term or short-term? This one question.
Yeah, most of the studies show from 1 to 3 years, and it's sustained. But these are for 1 to 3 years. So, but yeah, 20 years, we don't know actually, but this for 1 to 3 years, yes, it can be sustained.
According, we are talking about if there is any study or something that suggests if there is a long-term reduction or it's...
I think the most of the studies, the longest was like 3 years.
Okay. The second question is for, I think this one for Dr. Yahya. Is rupture anterior capsule in a child more urgent than that in adults? If we have a traumatic cataract in a children, yeah.
Yes, in a way, yes, because usually they progress very fast to total cataract, even if there is no much of cortical material in the anterior chamber. And the risk of amblyopia is an indication that you try to perform surgery as fast as you can, but with the best possible visual rehabilitation, keeping in mind that in children, the inflammatory reaction is usually very high. And in such cases, if you can do primary anterior vitrectomy, posterior capsulorhexis, and the anterior vitrectomy, will decrease the inflammatory process and the incidence of secondary posterior capsular opacification.
Thank you very much. We need also to move very fast, so a very short, please answer if we can do that. We have question, Dr. Rajesh. It's for regarding why we are having in Fuchs dystrophy visual acuity in the morning, worse in the morning, as you mentioned in your presentations.
It's because the drying effect or the desiccation effect is missing when the lids remain closed at night. So that's why the cornea.
We lost you.
Morning when you open it.
No, we are not hearing you, Dr. Rajesh. There is some interruption in your. No, your.
Okay, there must be some. Connection.
Yeah, now it's okay, but can you try again?
Yes,
the internet connection.
Internet connection is sometimes unstable. When you sleep at night, your lids are closed, so the drying effect on the cornea is missing. So the edema tends to worsen. And morning, when you open your eyes, because of the desiccation, the epithelial edema reduces.
Okay, that's okay. Is primary IOL implantation or secondary IOL implantation has better visual outcome after corneal perforation with traumatic cataract with rupture anterior capsule? Dr. Yahya?
It depends how big is the rupture. As we said, in my opinion, I prefer to do the surgery, the intraocular lens implantation later. If I can differ even the cataract surgery later, you can have better biometry and you can evaluate the corneal topography. So it's better to defer the implantation to later.
Already you have answered this question anyway, Dr. Yahya, so I will not go to the questions answered already. Most of it answered. Well done. That means we don't need to go through all, because I think someone on Dr. Yahya, you are typing the answer, right?
Yes.
Okay. So we are, because of the time, I would like to thank you all, but we are having now also Dr. Osama. He will give us also a talk. Dr. Osama, please go ahead. It is.
Uh,
So our session, it will be finished by around 5, before 5, yani. Okay. So we'll have now Dr. Osama.
Thank you, Dr. Mohammed, and thank you, Novartis. Is the screen okay now?
Yes, you are
So
online.
basically, I'm going to talk about inflammation pathway of dry eye disease, change from the cataract. So as you know,
It is part, Dr. Osama. We talk about ocular
it's part,
arthrosurface
but it's
disease. Yeah.
slightly from the main cataract. It's deeper. So go to the surface now, okay?
Service.
So as you know, those find dry eyes multifactorial disease of ocular surface characterized by loss of hemostasis of tear film, accompanied by ocular symptom in which tear film instability, hyperosmolarity, ocular surface inflammation, and damage and neurosensory abnormality play a theological part. Really, from the DUCE one, is they define that the dry eyes is a disease, not as a symptom, and really inflammation play a very important role than what we thought before. Patients present with dry eye can be characterized by a different spectrum of symptoms and usually coming to you with different symptoms like irritation, fluctuating vision, stinging. Some people feel like I feel dry without different prescription, but can also cause some pain, for a body sensation. It could be have reflex watering, as from dry eye, burning, or gritting sensation. But one important thing, the symptom may not correlated with the clinical sign what we see. So some patient you could see a lot of sign, but there's no symptom, and some people complain much of dry eye, but when you examine them, you don't see much signs. And it could be variable from day to day, the environment. If it's, people complain like in the office environment, they may have more dry eye, or the end of the day. It could affect one eye more than other. It could have a neuropathic involvement. So it's very, very important to assess clinical the dry eye and the severity of the patient. Look into the prevalence of dry eye. It's really in USA estimated like 34 million people had prevalence of dry eye. However, 17 million diagnosed, but the actual treated is very low, 1.6. And the same things apply for Europe, Japan, and Chinese. So we tend to be treating very lower number than what actually the prevalence of dry eye around us. And the dry itself, it can affect the patient, it can affect our job also. So patient ability to perform daily activity can be affected. People who wear contact lens, they may not able to wear it for very long. When you prescribe a glasses to the patient, that the glasses may find it not suitable for him and not good, and you ask they need to do the glass again, because unless you treat the dry eye, you may have not good refractive error correction, and the patient not be happy with the glasses. It also can affect the patient compliance with the medication, like patient with the glaucoma. They may less use drops because they're using a lot of other medication. It could also affect our surgery, like for cataract. It's the K reading, it may be not accurate. So when you do surgery, patient result may be not as good. The same things apply for when you do laser surgery. So if you don't correct the dry eye, you will not going to have a good refractive error to correct it. And also post-operative patient may have more complaint of symptoms, especially also for premium IOL, whereas unless you do dry eye treatment, it's very important to have a very happy patient if you treat dry eye before and avoid someone who's not controlled with dry eye. So basically look into the patient, like for example, the glaucoma. Patient with the glaucoma may take chronic topical preservative glaucoma medication, and that can affect to the dry eye disease. So it's very important really to avoid the preservative in such patient. And the prevalence of dry eye disease is very common, the glaucoma. And one of them is the medication. So almost 50% of patients with glaucoma had dry eye symptom. And also the patient, the more bottle he using medication, the more chances he had the dry eye. The same things also with compliance. So 4 of 10 patients with the glaucoma with dry eye disease, that the compliance of their glaucoma is less. So the mechanism of dry eye, as you know, it will be tear film instability, cause hyperosmolarity, cell damage, apoptosis, and nerve stimulation that cause inflammation. And the inflammation, it cause release of cytokine B9 and cause goblet cell loss, and that creating more instability and the versus cycle. The other cycle also, the meibomian gland dysfunction. So bacteria flora in the lid increase. It's a esterase lipase enzyme release toxins that will cause inflammation of the lid and the meibomian gland itself. It affects the lipid characteristic. The lipid become, it's not melting lipid, and that cause more inflammation. And there's too many factors from meibomian gland dysfunction to lid problem abnormality preservative, as you mentioned, allergy, contact lens, environment, conjunctivitis, neuropathy, or actual laser like cataract or cataract surgery, ocular surface problem, Sjogren, autoimmune, and hormonal, all can affecting dry eye and cycle. So unless we're treating the patient will, with dry eye, tends to get worse and worse. So it's very important to treat them to avoid long-term problem. This is referred to the meibomian gland dysfunction. So when you had the meibomian gland dysfunction, the quality and the quantity of the meibomian gland not good. So it's very thick meibomian gland obstructing the gland. It causes meibomian gland stasis. So the meibomian gland become dilated, then become atrophy. The same things also different factor like age, sex, hormonal, all contributed to what you call keratinization of the opening of the meibomian gland, and that causes obstruction, and all together will increase our evaporated dry eye. As you know, as the definition of dry eye is inflammatory disease, but with the dry eye, usually when we look into an inflammation, generally we're talking about inflammation means there should be redness, swelling, but in dry eye, although there's inflammation, patient may not have redness, may not have swelling on pain. One thing, as you know, for treatment of dry eye, all the studies, all the people and the guidelines we use, for example, that if the patient at the level 2 dry, where it's not controlled by lubricant and the environment improvement, this patient, they need anti-inflammatory treatment. So anti-inflammation in play very important role now for the treatment of dry eye. And there's different medication. We use it now to control the inflammation. Corticosteroid, we use it for a long time, as we know, cyclosporine, topical tacrolimus, azithromycin, tetracycline, and laphitagraph. That's the last. And we go by one. Corticosteroid, as you know, is acting against all the steps of the inflammation cascade. So really is a broad spectrum active anti-inflammatory. It's at the phagocytic level over the formation of inflammatory mediator, activation, lymphocyte, and also modulated of the immune reaction. So it's very important anti-inflammatory, and it works at different level, and there's different steroid availability, and everyone had different potency, but at the same times it's have different side effect. And we should know that corticosteroid in general, we worry about them for long term because it will cause cataract and glaucoma. But one advantage of them, they have very immediate effect. Cyclosporine is anti-inflammatory. It's an autoimmune modulator also. It's inhibit T cell mediation, inflammation, by inhibited interleukin-2 activity of the lymphocyte. So it's working in the lymphocyte. It takes some time because it's affecting the lymphocyte, so it's the afferent pathway. So any lymphocytes already produce it still cause inflammation. So it take a few weeks to have the full effect, and usually about 4 weeks to start, but maybe 2-3 months to have a full effect. Topical tacrolimus is another we're using also as anti-inflammatory. Usually it's a similar mechanism to the cyclosporine A. It blocks T lymphocytes activity, but it's also had more potency anti-autoimmune suppression than the cyclosporine. It suppresses autoimmune response by inhibiting the release of all other inflammatory cytokines like interleukin 3, 4, 5, 8, IVN, and TNF alpha. The other modality which now become popular to use as anti-inflammatory and using for dry eye is mainly for meibomian gland dysfunction. It's azithromycin. Azithromycin, as we know, is antibiotic. It will work in the bacteria on the lid margin, but also it has auto-inflammatory effect. So anti-inflammatory effect that's by inhibiting the production of arachnoid and pro-inflammatory factors. It's also inhibit the production inflammatory mediator by the phagocytic cells. So it's only antibiotic, but auto-inflammatory. But the other mechanism also, it help the secretion of the meibomian from the meibocytes. It has quick effect. It takes a few days to have effect, but the one advantage is to have a long tissue storage. Therefore, if you put it like usually we use it for 3 days, but it will last like 2-3 weeks the effect. Topical one and systemic, we had 2 options. And topical one, the only side effect is irritation, but no other complication from the topical one. The other modality, what we call doxycycline and tetracycline, we're using much longer before. It's inhibited in it will work in the bacterial enzyme lipase. which is degraded physical biomechanical for meibomian lipid, and that will work by reducing the formation of free lipids, which causing the irritation in the eye itself. It also have anti-MMP9 activity in the human cornea epithelium cells and the conjunctiva. It will take some time. The problem with the doxycycline, it will take a few weeks to have effect. And so we usually need to give it for like a month to 3 months, but they have a more side effect, systemic side effect, especially tummy upset, photosensitivity. So nowadays, really, I use more azithromycin than doxycycline for treating meibomian gland dysfunction with dry eye. Lafitagraft is a new treatment modality, which is it's a small molecule that binds to the cells. It's a lymphocytic adhesion molecule. We call it LFA1 that block interaction binding of the main binding receptor, the intercellular adhesion molecule they call ICAM1. Nowadays, there's a lot of people talking about ICAM1 because really ICAM1 we find it is very important in the dry eye disease. It's a upregulator inflammatory dry eye disease at different level in tissue, like in the endothelium of the blood vessel, in the stroma, and the conjunctiva and the cornea epithelium. It's result in inhibition of the T cell migration into the target cells at also a vascular endothelium cell, reduction of cytokines release, and reduction of further T cell recruitment. So basically, the lafitagraft is work at different levels. So initially, prevent the recognizing of the T cells and the migration of the T cells to the inflammatory area. So ICAM1 interact with the LFA1, as we say, and that involved the important process of antigen presenting that initiated what you call specific immune response. The adhesion molecule improve in mechanical binding between antigen presenting cell and lymphocytes in the region that itself, it will help to reduce the inflammation and promote the production of the inflammation. So it's by blocking the ICAM LF1 production that the antigen presenting cell, it will not producing any antibody. ICAM1 is overexpressed in dry eye disease. So ICAM, since we found that with different study, like this study look histopathology in the and using the creatinine 5 and 8 and ICAM staining in healthy eyes, but when patient who had the disease eye, dry eye disease, you find that the ICAM population is much more and it's overexpressed. So going to the immunosynapse promotion inflammation, it's the LF1 and in the T cells binding to the ICAM that forming what we call immunological synapse, which promote migration, proliferation, and survival and maturation of the T cells. Altogether, that increase expression of the ICAM, will allow the T cell recruitment more to the ocular surface and migration of the T cells from the blood vessel to the ocular surface, T cell activation. Altogether will release more inflammatory cytokines and cause more inflammation. So lafitagraft designed to block interaction, as we say, about between the LF1 and ICAM inhibitor, the immunological synapse. Lafitagraft demonstrates significant dose dependence. So the more dose and the longer, it will block the synapse formation and disrupted the existing synapse formation. Altogether will downstream the T cell function and prevent what you call T cell recruitment to the surface, and that by itself reducing the inflammatory cytokines release. So basically in a dry eye, the inflammation is, as we know, is very important role. So when you had inflammatory surface with any stress to the cornea or the conjunctiva, that release the interleukin like 6 and 1 and TNF, it's presented to what you call antigen cells, ABC, and that's taken to the lymphocyte. The lymphocytes are producing T cells, and the most common T cells really in the ocular surface, people talking about the T helper cell 17 and 1, which going to the afferent to the ocular surface and release it, and that cause inflammatory response in the ocular surface. So basically, laphitagraft is a good thing. It's working in both sides. It's the afferent pathway, so reducing the production of the inflammatory marker, and also efferent really prevent the migration of the T cells to ocular surface altogether. That will improve the inflammation. So altogether, really, if you look into anti-inflammatory theory and how it works, as you corticosteroid work in all area. Look into laphitagraft mainly worked in ICAM area, and cyclosporine and tacrolimus worked in the T cells interleukins. All together, they have different mechanism, and we could help each other to control the inflammation better. Look into the meibomian gland dysfunction and dry eye. It's like lid hygiene. It can improve the lid production, reduce the bacterial flora, but orodoxycycline and azithromycin can reduce the lipase and the esterase enzyme to break down the meibomian gland, to reduce the inflammation further. Steroid, laphitagraft, cyclosporine, omega-3, and the orodoxycycline, azithromycin all can work to reduce the inflammation. And altogether, really, is multifactorial. If we control it, that will improve the ocular surface disease and inflammatory of the dry eye. One study looked into MBB9, as you know, is the key cytokines. It's raised in early stage inflammation cascade. Therefore, it's a good biomarker. When there's an inflammation, the MBB9, it will be raised. And nowadays is good in the clinic. We can assess the MBB9. And this study is looking at the divide patient. If someone had MBB9 positive, they're using the anti-inflammatory drops like cyclosporine or laphitagraft or steroid. But if it's is low, then using lubricant initially before going. The one study look at really the presence or absence of ocular inflammation, and that's related to the effect of the anti-inflammatory medication. In this study, show if someone had a clinical significant inflammation, only 0.5% of the patient will have a symptomatic dry eye. And if we treated this patient with the steroid topically, it's not 0.5% of them improve it. However, if we did MBB9, which that will show that he had more significant inflammation, this patient, 85% of the patient improve it by the course of steroid. So really maybe a good thing to, if we use MBB9, it's just help us to see, other than just the clinical examination, this patient had clinical inflammation from the dry eye, and that we expect this patient to be benefit from anti-inflammatory drops. And that hopefully that will change our way to treat dry eyes for future. Going to the laphitagraft 5% treatment for dry eye, it's looking to the study combined efficiency, safety, and outcome of a 5 randomized controlled trial, which has been used for the FDA approval for the laphitagraft. Basically, laphitagraft, as we say, it work against design to inhibit dry eye disease associated inflammation. It's approved by US FDA. It's also approved in Canada, and in UAE, hopefully it's approved, and hopefully in a couple of months we're going to have it. So we'll be the 3rd country in the world to have the laphitagraft available here. Look into efficiency and safety, evaluation of 84 days trial. And there's another study, Sonata, which is a 5th study looking for the safety and tolerability of laphitagraft. So they evaluate the evidence from the 5 clinical trial, phase 2, OBIS 1, OBIS 2, OBIS 3, and Sonata. And the response analysis proportion subject who achieved defined reduction in tear dryness in the 2 trial or similar design. So basically, look into the 5 randomized control study. Patients have laphitagraft or placebo, and so every study looking for, they have different primary sign point. Usually looking to inferior corneal staining score, most of them, and the end point looking mainly for the eye dry score. And basically, look into the corneal stain and compare it all the study. The OPTIS 2 and OPTIS 3, that's a study looking to the moderate to severe dry eye who had dry symptom, but also he had the score more than 40%. Look into the pool, total pool of the patient was 2,464 patients divided between placebo and levetiracetam. It was almost similar range of the group. Most of the mean age is almost like 50% of the patient. It was above 65 years old, and female was more than male, as you know, is almost 3 times, which is represented the normal population. And the ratio was mixed between white, half of them, and less non-white, because it's done in Americas, you know. And the main duration of the treatment, it was for levetiracetam 118 days and the placebo 113 days. So look into the signs. So basically, we look into the inferior corneal staining and look into the from day 14, 42, and 84. And the levetiracetam seems to be fast acting. So after 2 weeks, there's a significant drop in the sign of the patient, and the sign tends to improve with the time, compared with the placebo. So it's in phase 2 and Optus 1, and also in Optus 3 shows significant improvement in the sign. However, the other study, Optus 2, show no statistical significant. Look into the symptoms, basically look into the eye dryness score, and that's the patient's symptom is improved very quick, 2 weeks. And if you look to the curve, it's the patient with the time improving until this study designed for 84 days. And the more time use it, the more significant the drop. And so basically the eye dry score dropped significantly in Optus 2, 3, and also showed in Optus 1. Regarding the look into analysis to see the percentage change from the baseline of dryness eye score. So basically look into how many patients like 30% improvement, 50% improvement, or 70% improvement. All of them show statistically significant drop in the levetiracetam compared with the placebo. And if you look at, like, for example, at 14 days, 30% reduction group, levetiracetam in the 2 study almost like 50% drop compared with the placebo, which is like 33. Look into the safety. So basically look into the treatment emerged adverse event. And basically most of the symptom is very mild or moderate. No serious ocular surface adverse event happening. And the withdrawal from the screen is not, withdrawal from the study is very low. So it's almost 7% compared with the placebo, 2.6. The most common adverse event after 12-week use, it's pain, which is almost 11%, irritation, burning, 15%, reaction at the surface like some redness, 12%, and 14% people they feel the test of the medication. Although most of them is mild, the only thing I think the feeling of the test of the drugs is slightly, some of them is more moderate, but none of them have a serious ocular surface event. There's a 23 participant, which is 1.1% in the levetiracetam and 1% in the vehicle. They show serious non-ocular side effect, and most likely it's not related to the medication itself, because it's very similar, the event between the levetiracetam and the vehicle. Look into overall discontinuous rate of between the levetiracetam and the vehicle. It's 5.7% compared to 1.9% of the vehicle, the patient discontinuous. And the main reason for the discontinuous is really it's 0.6 pain, irritation at the side, burning, and feeling the test of the medication. But it's still very low percentage compared with the other medication. So not a safety study. This basically look into the safety, and also they did look to when the patient using levetiracetam, they allowed them to use artificial tear, and look in how many patients they still need artificial tear supplement while he's in levetiracetam. So basically, they're looking at 90 days, 180, and 270, and 1 year almost. And this is so 18% of the patient who use Lafitograph, they using the Lafitograph without any artificial tear. Compared with the control one, it's 33%. They need to use artificial tear as a supplement than the vehicle. Conclusion: inflammation play an important role in the cause of dry eye disease and need to be treated. Different medication can be used to control dry eye disease alone, or I think combination. Usually most of us using steroid for short period and using another modality to control long-term treatment. Lafitograph improves sign and symptom of dry eye disease over 12 weeks trial in both OBIS 2 and OBIS 3. High proportion of dry eye subject achieve reduction eye dryness score, so it's improved the symptom compared with the placebo. And the Lafitograph ophthalmic solution 5%, it was well tolerated, no serious ocular side effect. Clinical evidence from the 5 studies show Lafitograph is efficient, well tolerated for treatment of dry eye disease and symptom. And really, I'm looking forward to have it in UE and to use it. Still, I haven't had the clinical. I haven't used it yet, the clinical, because it's not yet available. But hopefully, very soon we'll have it. Will help us to control our dry eye patient better. And thank you very much.
Thank you very much, Dr. Usama, for this nice presentation about new drugs that all of us waiting for that, so we can offer our patients a new other treatments. We are having few questions, so we can go very fast. I have one. It is in actually send it through a chat about, I think this one, I think for Dr. Hamdi, using endoscopy in anterior chamber in corneal opacity, or anyone, if there is anyone have an experience, if there is any corneal opacity and you are using an endoscopy in AC. Anyone have any experience with that? Dr. Yahya, Dr. Muhammad, Rajesh, or Hamdi?
Actually, I don't have an experience with that, but I think once you need to go with an endoscope inside the eye in order to be able to see, I think you are in the stage that you have to do something with the cornea, either doing DALK or doing a bit of keratoplasty.
But one of the things, I have no experience with Dr. Hamdi, but one of the tricks that you can use in denser opacity, to use endo-illumination externally, you put it at the limbus, and this helps you to deal with the capsule and the cataract, even in the presence of denser opacity.
You mean, Doctor, in the limbal you are putting externally?
Yeah, externally.
Yes.
Most people use external.
Just pushing against the limbal area. Okay, excellent. There is questions here. With many artificial eye drops available, this I think for Usama available, is there any preference to use any specific eye drops for aqueous mucin deficiency state?
I think it's too many. What's good? I think most important really preservative. Okay, try to use a preservative free or the new preservative which is not toxic to the eye. That's very important. The second thing depends what the patient demands. So some patient wanted to have a fewer drops, long acting, last longer. But the problem, the more viscosity, the more blurry the vision. So there's a patient choice. There's an implement. The second thing is it the single-use one. I find it's very easy to carry with the patient, less risk of heat damage on the storage. So I prefer to use the single-use, but I leave it to the patient also to choose what he preferred to.
Because we want also a very short, because we have only 1 minute. Okay, what is the indication of using anti-inflammatory agent in dry eye?
Basically, the patient
depending on what?
Basically, it depends on the sign and symptom of the patient. If it's very mild dry eye, use lubricant. But if it's not controlled with lubricant, you're going to use anti-inflammatory.
Okay.
But
so you don't need to do any investigation to do for that. Okay.
And benign if you want to use.
Someone is asking about Dr. Shabir is asking about tacrolimus eye drops are available locally.
Ointment we had the skin one. We have not licensed for eyes, but it's very burning. But is I think in India now they have it, by the way, for eyes available.
Okay. Do we have Dina? There is teams. Our teams. If there any time for raise hand, there is one from Dr. Naeem or Dr. Naima from Naima. If there is a chance, okay, prepare for her. If there is no times, because already we are over that time.
But tacrolimus is good. Tacrolimus, Mohammed, usually using for very severe inflammatory eye disease, not only dry eye.
Okay. How reversible is the change in eyelid edge due to a conjunctivalization of inner eyelid edge?
Depends on how much is it's if you treat it early, it can be reversed, but not necessarily. That's why it's very important to treat this patient well, because the more damage, the more blocked the gland inflammation, the gland, Meibomian gland, become atrophy after time. So there's no, the gland is damaged and doesn't reverse.
I think we are already on times, and unfortunately, we are having only 15 minutes.
Muhammad.
Fast, Hamdi.
The tacrolimus, I have used it once for a patient with a secondary keratitis. It's one of the indications, and it is nicely effective. Within 1 week, every piece of this opacity in the cornea disappeared.
Okay, this is another experience. Very nice. Thank you, Hamdi, for adding. And before we close, I would like to thank you all. Thanks for your time, for your information, for sharing with us your experience. And we hope to see you soon, inshallah. Our people, or participants, they are around 450 and more. Only this one on Zoom. We are having also, I want to announce for all that we are having also a live on Facebook and YouTube, and there is many people, they are following us. Thank you for all, and we'll see you after 15 minutes in the other session. Thanks a lot. Thank Dr. Yahya, Dr. Hamdi, Dr. Usama, Dr. Imad, Dr. Muhammad Ali, and Dr. also Rajesh. And also thanks for also Novartis for being with us in this session in their symposium. Thanks a lot, and
thank you.
Goodbye.
Thank you.
Bye-bye.
Thank you very much. Thank you.